Sim, está ligado.
Bem, muito bom dia a todas e a todos, e em nome da Associação Portuguesa pelos Direitos da Mulher na Gravidez e no Parto, eu dou as boas-vindas a este Nascer em Amor, a edição de 2018. Peço desculpa pelo atraso, em primeiro lugar, em nome da organização. Tivemos alguns constrangimentos em conseguir chegar aqui em tempo útil, tanto nós, da parte da organização, como alguns dos nossos convidados e das pessoas que estavam inscritas. Mas vamos tentar recuperar o tempo ao longo do dia. Eu vou já passar a palavra a Maria João Delgado, que é docente e é representante do Departamento de Enfermagem de Saúde Materna e representante também da direção da Escola de Enfermagem de Lisboa, que nos acolhe aqui hoje. Muito obrigado.
Ora, muito bom dia. Estou aqui, como o Mário já disse, na qualidade de representante dos anfitriões deste evento e, portanto, cabe-me dizer as primeiras palavras. Em primeiro lugar, queria dar as boas-vindas a todos os presentes, aos membros da Associação Portuguesa pelos Direitos da Mulher na Gravidez e Parto, a todos os oradores e também a todos os participantes neste evento. Isso faço em meu nome pessoal e, sobretudo, em nome da direção da ESL e em nome do Departamento de Enfermagem de Saúde Materna. Quero também dar os parabéns à Associação pelo excepcional programa, quer pela qualidade dos oradores, quer pela qualidade e a pertinência e a atualidade dos temas abordados. Quero felicitar também as duas instituições pelo protocolo que hoje se celebra. Um protocolo que pensamos que a interação entre estas duas instituições vai ajudá-las a perseguir os seus objetivos e a sua missão. A ESL congratula-se com mais esta oportunidade de dar também persecução à sua missão e aos seus valores, que vem no sentido de ser uma escola que se relaciona com o seu contexto social e também uma escola que estimula a participação e a cidadania e, por isso, pretende prestar um serviço público de qualidade. Muito obrigada pela vossa atenção.
Vou passar agora a palavra à Sara Duval, Presidente da Associação Portuguesa pelos Direitos da Mulher na Gravidez e no Parto.
Então, bom dia a todas e a todos. E em nome da equipa da Associação Portuguesa pelos Direitos da Mulher na Gravidez e Parto, sejam todos muito bem-vindos, muito bem-vindas. Gostava de agradecer a vossa presença. Gostava também de agradecer ao ESL o fantástico acolhimento, não só hoje, como durante todo este processo, e também a celebração deste protocolo, porque um dos intuitos da associação e o objetivo da associação ter surgido era precisamente construírem-se pontes e podermos realmente tornar este um país um pouco melhor para se nascer. Gostava de agradecer também aos nossos parceiros, aos nossos apoiantes, mas principalmente, e é preciso dizê-lo, eu gostava de quebrar aqui um pouco o protocolo e a ordem em que se agradecem as coisas e agradecer à equipa da Associação Portuguesa pelos Direitos da Mulher na Gravidez e Parto, que é totalmente voluntária e que organiza não só este evento, como todo o trabalho da associação, de forma voluntária, nas suas horas vagas inexistentes, conciliando trabalho, família e, portanto, aqui fica oficialmente e convido-vos também a agradecer todo este trabalho e este evento que demorou meses. Isto é quase um parto, pronto. Felizmente com a data muito definida. Gostava também de agradecer às nossas oradoras e oradores, por virem partilhar um pouco da sua sabedoria, da sua experiência, em especial ao Dr. Stuart Fischbein, que aceitou vir de tão longe, de Los Angeles, e aceitou não ficar on call durante 2 semanas, o que é muito difícil para ele, para poder vir aqui partilhar connosco a sua experiência e dar também a formação de parto pélvico, que aconteceu ontem no Hospital Garcia de Horta e vai acontecer segunda-feira no Hospital da Póvoa. Portanto, nós hoje estamos a encerrar a Semana Mundial pelo Parto Respeitado, cujo tema era menos interferência, mais cuidados. E nesse sentido, o nosso maior, mais sincero e caloroso agradecimento vai para as 4 mulheres que hoje vêm aqui contar a sua história, segundo o tema do Nascer em Amor, partos excepcionais. Portanto, nós agradecemos a sua generosidade em virem partilhar momentos tão únicos e tão privados que é a história de parto do nosso bebê. Esta associação surgiu pelas mulheres, para as mulheres, e as mulheres serão sempre o nosso foco e, portanto, um enorme obrigada a todas elas. Algumas já chegaram, outras não. E hoje a associação gostava de vos fazer um apelo, vendo tantas pessoas aqui hoje reunidas. Gostávamos que pegassem em toda a informação, toda a inspiração e toda a oxitocina que se gera sempre nestes eventos e que levem um bocadinho dessa luz e que mudem qualquer coisa, ou no vosso local de trabalho, se trabalharem no sistema de cuidados de saúde materna, na vossa comunidade, por mais pequena que seja, que consigam trazer esta mudança, porque o sistema, afinal, somos todos nós. Não são eles, não são os outros, somos nós, na nossa prática diária, como mulheres mais informadas, como profissionais mais calorosos e mais abertos a ouvir as mulheres. E, de facto, é muito importante passar das palavras à ação. Não chega concordar, ouvir e acenar. É mesmo importante tomar ação, sairmos da nossa zona de conforto para realmente podermos nascer melhor, não só em Portugal, como no mundo. Mas, olhando para tanta gente, umas mais conhecidas, já nossas conhecidas, outras não, tantas pessoas aqui hoje, entre mulheres, profissionais e ativistas, acho que o futuro pode ser muito risonho. Obrigada. Então, pronto, agora vamos oficializar o protocolo, vamos trocar os galhardetes. Obrigada. Ok, pronto, sim.
Muito obrigado. Houve uma alteração no programa. Desculpem. Houve uma pequena alteração no programa, agora da parte da manhã, e vamos ter já connosco Stuart Fischbein, que eu vou convidar a juntar-se a mim aqui ao palco dentro de um momento. Stuart Fischbein é médico ginecologista e obstetra na Birthing Instincts, é membro do Colégio Americano de Obstetrícia e Ginecologia, é autor do livro em inglês Fearless Pregnancy, Wisdom and Reassurance from a Doctor, a Midwife and a Mom, e vários artigos. Tem um conhecido podcast, o Dr. Stu Podcast, que é seguido por uma audiência internacional e atualmente trabalha diretamente com parteiras que acompanham partos em casa e oferece alguma esperança a mulheres que não conseguem encontrar profissionais que as apoiem no seu parto vaginal após cesariana, ou em partos de gêmeos, ou em partos pélvicos. E vai falar-nos sobre consentimento. Muito obrigado. Thank you. Thank you very much. The floor is yours. I'll just ask you to turn off the microphone when you finish your presentation.
How do I do that?
No, just click here.
Got it.
And you are free to stay here or to sit down over there.
Do I need this while I'm talking?
Not when you're talking. Yes.
Okay.
Hopefully not.
But they have it. They have
yes.
it. Okay.
Anyone who needs it has it. Okay.
Okay, and then I'm just trying to see how I just do this. Boom, boom. Okay, great.
Yeah, is it working?
Okay, great. Can everyone hear me? Can anyone not hear me? Can anyone not hear me? Okay. Does everyone either understand English or have the translator? Everybody's good. Okay. I am very, very honored to be here today. I want to thank Sarah and the rest of the team for contacting me, finding me, and asking me to come. It's really an honor for me. Sometimes we feel like we're fighting a very lonely battle when we do sort of things that are out of the mainstream. And I, being a home birth obstetrician in Southern California, am completely out of the mainstream in my area. I work with midwives. I have worked directly with midwives for 8 years. Prior to that, I backed midwives in a hospital setting for 25 years. But it came to a head when I was doing things that the hospital began to tell me I couldn't do anymore. They didn't want me to back midwives or work with midwives. They didn't want me to do breech delivery. They didn't want me to do vaginal birth after cesarean. And these were not choices that I felt the hospital had the right to determine. And so we got into a battle, and they're big and I'm small. And so small people tend to lose those battles. So I chose to go off and be working in the home and the birthing center setting. And it's the best decision that ever happened to me. But sometimes you find that you feels very much alone. Other than the friends that you have in the medical community, I'm sort of an outlier. But when I come to something like this, and I see all of you, and I've had the conversations I've had this morning with several people I've met just today, or some of the wonderful people I met yesterday, I'm re-energized and rejuvenated to go on with the push to try to get what I consider to be normal human rights to become the mainstream as opposed to the extreme. So today I'm going to talk about, informed consent and respect for individual autonomy. I'm relating mostly to what's going on in my country. I've tried to bring in other parts, but I only am an expert in what I know, and I don't want to presume too much, but I know from talking to people here that the problems that I have in my country are either the same or worse in many of the countries in Europe. And I want to just re-emphasize these things. So these are my objectives for that by the end of the 45-minute talk today, that you will be able to understand these. Can everybody read English, or should I read it out loud so the translator does it? What's the best thing to do here? Okay. Sure. How can I change it on the computer here, though? Here, hang on. See, it's still on the first screen here. How do I get it to go to that one? I just have to click on that, but that won't change that. Okay. Well, anyway, I'll read it from here. Yeah. This is the only one. Well, no, I actually have to read them all then, don't I? No. Well, they're all in English.
Yeah, okay, but I think alguém tem dificuldade em seguir o que está escrito em inglês, para além do que alguém precisa que seja lido o que está no PowerPoint. Se alguém precisar, está tudo bem, mas precisamos só que levante a mão só para avisar. Ok, o tradutor diz que vai conseguir ler o que está e traduzir o que está no PowerPoint, por isso não haverá problema. The translator says that he will do that, so you don't need to do. You just present what you.
And he'll read.
Yeah.
Okay.
He'll do that.
Okay, great. All right. So, thank you. This is the first time I've actually spoken to an audience that doesn't speak my language, so it's fun for me. It really is fun for me to be here, and my daughter's here with me, but she's off to Sintra today, enjoying herself. So what I hope to be accomplished today will be that you will understand the legal and ethical rights concerning medical care, and those of us that provide it. Using examples, we will recognize how information and consent is often manipulated, and then we'll leave hopefully all of you with better suited to assist and advocate in the decision-making process for yourselves, your clients, and your loved ones. Okay, now it's only working there, so. Okay, so now, Mario? Now it's only changing it here and not there.
Has a wheel of its own.
Yeah, see, now it changes it here but not there. So what do we do? Just
no, the technician is doing something with it. Wait.
Okay. Thank you for your patience, everybody.
Yeah, he's coming.
Yeah, I think it's because I hit that box. See, now it's changing it here, but not the complexity or uncertainty over what to do in a different situation. So informed consent is really a quandary. The American Medical Association Code of Ethics states that, and this is really important because we talked about this a little yesterday at the breech training, but rational informed patients should not be expected to act uniformly, even under similar circumstances, in agreeing to or refusing treatment. In other words, if I were to counsel two of you people exactly the same way, all right, you might come to two different decisions because you have different life experiences, you have different needs, different wants. Some of you may think a risk of 1 in 1,000 is really not a great risk. Some of you may think a risk of 1 in 1,000 is too high a risk. So it's not for me to tell you what to do, but it's for me to accept the fact that every time I counsel a person, I'm not exactly sure how they're going to respond, and to be open to that. The American Medical Association also says the patient's right of self-decision can be effectively exercised only if a patient possesses enough information to enable an informed choice. The patient should make his or her determination about treatment. Okay, we all know that, we hear it all the time, and yet every day, any of us who practice in a hospital setting or even in other settings know that these tenets of the American Medical Association or tenets of general ethics are violated every single day. We have an ethical obligation to help the patient make choices from among the therapeutic alternatives consistent with good medical practice. Informed consent is a basic policy in both ethics and law that physicians and midwives and all healthcare professionals must honor. All right? The question is, what is good medical practice? All right? What I think is good medical practice is probably not the same as what a doctor in a different hospital or a doctor who doesn't think home birth or doesn't want to do breech or doesn't want to do VBAC thinks is good medical practice. So who defines it? And this is really an interesting thing because it's a setup for conflict. Does that make sense? Okay. So some people say it's community standards. What's everyone do in a certain community? Well, in that case, if you're the only midwife in a community, then you're beneath the standard. All right? If I'm the only physician who does laparoscopic surgery in a given community, I'm beneath the standard. All right? That means no innovation can ever come into your community because if you use community standards as your gold standard, then that's what the majority of physicians or practitioners in your community do. And if nobody does breeches or nobody does twins, then for somebody to come in and say, I'm good at breeches, I'll do them, you will be considered an outlier and be ostracized. What if it's the practitioners themselves that decide? All right. Well, then you could have 100 different, definitions for good medical practice. So that's probably not a good idea. Should hospital risk managers decide what's good medical practice? Well, in many hospitals, they actually do. All right. They're practicing medicine. What we say in the United States, you're practicing medicine without a license, because they are the people that basically control what goes on in a hospital, at least in my country. And if they don't like something, then a policy will be made telling you can't do that. Like, for instance, at Johns Hopkins University for twins, they have a policy that says everyone with twins has to have an IV and has to have an epidural. Okay? That policy is put in place through the risk management department, the anesthesia department, the OB department, all getting together and saying, this is what we're going to do. All right? Is that good medical practice? I don't, I'm leaving these open-ended questions for you. You already know my answer to them, all right? Should national organizations decide what's good medical practice? Should the Royal College of OBGYN or the American College of OBGYN or the American Medical Association, or I don't know what European association, should they be the ones that decide what's good medical practice? Again, these are all open-ended questions because these are the kind of things that you will face in if you go into a community where what you want to do or what you think is ethically correct to do for your client is met with resistance. I don't know, you probably have these here. We certainly have them in the United States. A lot of things that we do in the United States is done to prevent liability. It's fear of litigation. And so therefore, are they the ones that are establishing good medical practice? Should patients decide? All right? You know, patients don't have a lot of knowledge when it comes to specific details of good medical practice, yet ultimately, they should be the final arbiters of what happens. But then that generally isn't what we see. Patients usually are the last ones to get to decide what's good medical practice. How about insurance companies? You guys have two different types of care here. I think you have the private care and the government health care. So in the private care, you may or may not have access to things because they may or not be covered. And if they're not covered and they're financially unattainable, or untenable, excuse me, then you can't do them. Are they deciding what's good medical practice? And then lastly, of course, is the government. Does the government, should the government make decisions for us? They do it by financial incentives or by disincentives, by taxing, by giving benefits in certain things. They direct you. You may want one certain medication, but that may not be on the government formulary, and you may only end up with a different medication. So they're actually deciding in that community or that city or that country what is good medical practice. These are all real dilemmas. This is why the talk is called a quandary, because I don't have answers for these things. I do, but no one, you know, no one's going to listen to me when it comes to these decisions. But ultimately, these are the problems that when you try to discuss ethics and discuss advocating for your clients, you have to deal with potentially all of these which are in conflict with each other. Okay, ethics and decision making. There are tenets in ethics. The main one that's been used for most of my career is something called beneficence-based ethics. Beneficence-based ethics is simply defined as a responsibility of a practitioner to give information to their clients, and if that information, once that information is given, then to respect the decision made by the client. That is the general tenet of beneficence-based ethics. So that means that ultimately our job is to give information and then respect individual autonomy. All right. If you go back but there's another big thing that comes into the decision-making process, and that's something called fiduciary duty. My fiduciary duty as a physician is to my patient. All right, everybody understand that? Fiduciary duty is what your financial responsibility is to not for yourself, but for your patient. But if we go back to the previous slide and say you're a hospital risk manager, what's your fiduciary duty? To the hospital, all right? And say you're a physician who's employed by the hospital and whose employment is dictated by how you comply to the hospital's guidelines. And the hospital says, we don't do this medicine, or we don't do this procedure. But you think that that medicine or procedure is the best for your patient. But if you give them that information, then the hospital may get mad at you. So ultimately, your fiduciary duty, is it to the patient? Is it to the hospital? Is it to your family so that you can bring home a paycheck? A lot of conflicts there. And it's conflicting. But conflicts of interest should be resolved in accordance with the best interests of the patient, respecting a woman's autonomy to make healthcare decisions, okay? This has come from the American College of OBGYN's Code of Professional Ethics. So even if you have fiduciary duties to other things, all right, ultimately you're the patient you're supposed to be responsible to. But try telling that to a hospital chief financial officer. His chief fiduciary duty is to the stockholders who own the company or own the hospital, not to the individual patient. We fall way down on the totem pole. You guys know what a totem pole is? Okay, so it's an Indian thing where they have different faces all stacked up, and when you, it's a slang term we use when you're at the bottom of the totem pole. It means that you're, you know, in last place, technically speaking. Okay, I want to talk about shared decision-making, because shared decision-making is something we all hear, and it sounds like a pretty good idea, okay, because it puts people at the center of decisions about their own care and treatment. During the shared decision-making, it's important that the care or treatment options are fully explored along with the risks and benefits. Different choices available to the patient are discussed, and the decision is reached together with a health and social care professional. So this is a tenet that's been around for more than a decade. I always thought it seemed like a reasonable idea until I talked to a friend of mine named Hermine Hayes-Klein. Hermine Hayes-Klein is a human rights attorney. Some of you may have recognized her name. And what she has told me a couple things is shared decision-making is a reassuring phrase often used to inform and advise the process of consent. However, it's not really an accurate term, as time constraints and communication skills are often limiting of how good shared decision-making can be. Because the way the medical model is set up is that many doctors don't have the time in their daily schedule because of the volume of patients they must see in order to give someone full informed consent, and therefore how do you share decision-making with someone when you're not giving them all the information? Shared decision-making is subservient and must be subservient to informed consent and refusal. So in other words, we can offer all the shared decision-making we want, and your doctor says, you know, we do breech delivery, we don't do breech delivery, we think it's a bad idea. But ultimately, if you say, I want a breech delivery, that should trump everything else. This is a simple tenet that many of us in this room probably realize, but I can tell you most of my colleagues do not in the medical world, that before you can even touch the patient's body, the patient must give you free informed consent, or free consent. So in other words, when I have a woman in my office and I'm going to measure her belly with a tape measure, all right, for 20 years I just took out the tape measure and measured her belly. And then I began talking to midwives, and midwives would always say, would it be okay if I touch your belly? Very simple statement. Never had any woman say no. Sometimes they say yes, but I'm a little ticklish, so be careful. But they never say no, all right? Or I'm going to examine you now, or this is what I'm going to do. I mean, how many of us have heard about obstetrics violence where we've heard women complain that someone has done a vaginal exam or broken the bag of waters or done something without any informed consent whatsoever? That's actually a violation. That's actually illegal, and it's a violation of all tenets of medical ethics. You cannot touch another person's body without their permission. There are 3 prongs to consent, all right? The first prong is called inform, and that's an objective part of consent. It's to give the information that's relevant to help them make a decision. And when you inform somebody, you need to give them the risks and benefits of what you're doing, but also the risks and benefits of not doing what you're doing. So in other words, when we talk about VBAC, a lot of doctors will give the risks and benefits of a VBAC to a client, but they'll assume that cesarean section is totally safe, and they don't give any risks and benefits to cesarean section. You must give objective information on all aspects. The second one is to advise, all right? Now, this is a subjective thing, and a doctor has experience, a midwife has experience, and if a client asks them, well, what do you think? Then you have the right to give them your opinion. And you should give them your opinion. And then they can take your opinion into their decision-making process. And they may agree with your opinion, or they may disagree with your opinion, or they may have more questions about your opinion. And then they have the right to ask them. And again, this is all time-consuming. And it's why informed consent looks like at a hospital, a woman coming in labor and handed a piece of paper which she's supposed to sign, and that's it. All right? That is not informed consent, but that's, I guess, what the lawyers of the hospital think will satisfy if there's a problem. but it really doesn't stand up in court because you really haven't given people information objectively, advice subjectively, and then support. And support means whether for or against the advice, your job is to support that person. Right? The only instance where that's not necessarily true is if there is no option. All right? Like if a woman comes in demanding a breech delivery, all right, and there's no one in the institution that knows how to do it, all right, you don't have to say, okay, I'll do it. But what you should say to them is, you know what, no one here knows how to do it, but there's a practitioner over at that building or that institution that does, maybe you should go there. As opposed to saying something like, well, you'd be an idiot to have a breech baby because the baby's head will get stuck and your baby will die. All right? Which is one way of saying what people will say when they don't know how to do breech delivery. They'll talk people out of it by skewing their consent. Everybody following so far? I'm not talking too fast? Okay. Informed consent, I've categorized it into 3 types of informed consent. True informed consent, which is the full assessment of risks and benefits of all options. And my question to all of us is this really possible? And my answer is no, it's not really possible. I mean, if you're going to give someone a shot of lidocaine, do you have to tell them that they could have anaphylaxis and die 1 in a million times? I mean, what's the cutoff? 1 in 1,000 risk? 1 in 100,000 risk? I mean, I don't know if you have commercials on television here in Portugal from pharmaceutical companies, where about 10 seconds will be about the drug, and the last 20 seconds will be somebody talking really, really fast about all the terrible side effects that go along with it, okay? That always gets me. They're trying to give you true informed consent, but they really can't do that because they talk so fast you understand nothing but bloody diarrhea is about all you ever hear. So the next one is selective informed consent, and this is more reality for me. It's limiting consent to those risks and benefits which can reasonably be expected to occur. And then lastly, of course, is the one that's most commonly used, and that's what I would call skewed informed consent. And this is sad because bias is inserted to give selective risks and benefits in order to funnel a person down the path that the practitioner or the hospital or the risk managers or the insurance company want them to take. And this is done all too common. And in my position as an outspoken advocate for home birth and informed choice, my email box, my Facebook message box, my text messaging gets filled up every day. There isn't a day goes by that I don't get somebody telling me, sending me something and saying, this is what my doctor said, what do you think? And it's like, I want to pull my hair out because it's so obvious that the doctor has skewed his consent to get them to try to do what the hospital or what the doctor wants. All right, so let's have some real life examples here. Let's talk a little bit about what I just went over and put it into perspective. VBAC, something that we all know about, vaginal birth after cesarean. Most of the world literature supports this decision, yet there are many hospitals that either have an outright ban or what we call a de facto ban. A de facto ban is simply that they don't officially ban it, but there's no one in the hospital that will do it, so therefore it becomes a ban. I like this slide only because it says thousands of bulldogs can't be wrong, because a friend of mine is a breeder of French bulldogs, and French bulldogs are bred where their heads are too big to come out of their mothers, so all French bulldogs are born by cesarean section. So anyway, I just think that if you get into it, there's a thing about that I consider ethics and math. When I went to the NIH consensus meeting in 2010 in Bethesda, Maryland at the NIH, I actually got up and asked this question of the panel because they were quoting these things, and it says, a successful VBAC, we all agree, carries less risk to the mother than an elective repeat cesarean section. And everyone agreed. And then I looked at the panel and I said, and you guys have just said that 70–80% of attempted VBACs, or what we call trial of labor after cesarean, will be successful. And they all agreed. So then I said, therefore, a hospital that prohibits trials of labor after cesarean are forcing 70–80% of women to undergo a surgery that puts them at their babies at greater risk of injury. All right? How is that possibly ethical? How is that possibly informed consent? And yet, that goes on in my country. I suspect it goes on in your country. Yep, there's some yeses out there. And yet, they go about their job every day thinking that they're doing fine. So here's a good question. I'll digress for just a second. Here's a good question. How do good people end up supporting those policies? They don't go home every night and go, hey, honey, I just did 3 unnecessary C-sections today. All right? They don't do that. So they have what's called cognitive dissonance. And I don't know how you translate that, but cognitive dissonance is a very powerful tool that we use to push out things that don't meet with our belief system or ridicule them, and then selectively choose things that support our foundation, that make us feel better. So if there's an article that comes out that's anti-VBAC, it's all over the news. But if it's pro-VBAC, that doesn't come up at the conferences. And that's sort of what they do, because these are not bad people that we're dealing with, but they have really bad ideas and bad policies, and they've lost their way when it comes to medical ethics. I don't know what they would say if they heard a lecture like this. The people that really should be hearing a lecture like this are the people that aren't here today. Okay, also, ACOG put out a committee opinion just recently, like 2 years ago, about coercion. And you may have seen it. I think what comes out of America does get transferred around the world. But they said the use of coercion is not only ethically impermissible, but also medically inadvisable because of the realities of prognostic uncertainty and the limitations of medical knowledge. In other words, you shouldn't tell a woman she has to have a C-section because her baby is too big, all right? Because the baby will have a shoulder dystocia. We know shoulder dystocias are not predictable, and we know women often deliver big babies. So the prognostic uncertainty of that statement makes that sort of statement a coercive statement, and that's something that should not be done. It's never acceptable for OBGYNs to attempt to influence patients toward a clinical decision using coercion, all right? ACOG says that. How many doctors that belong to ACOG, like me, I'm a fellow, believe that, follow that, do that? I don't think very many. But if ACOG says something like, don't do breech delivery at home, oh yeah, we're all for that, all right? Because that one fits with their model, but this one bothers them. So they have to sort of ignore this one. They have to pretend that it doesn't say what it says. Informed refusal means no. Patient has the right to say no, and no means no. We all know that, all right? Especially in the era of the hashtag #MeToo thing and the obstetric violence thing, we really want to make it clear that no means no. Patient's decision to decline recommended treatment after all options, risks, and benefits have been thoroughly explained is informed refusal. They have the right, even if everyone around them thinks they should do it, to say no. But here's a new twist, okay? Because they also have the right of uninformed refusal. In other words, even a woman who doesn't know anything, who hasn't been told anything or doesn't understand anything, still has the right to say, no, don't touch me. No, don't operate on me. That's their right. Okay? That's a new thing to me that came up in discussion just recently, that, you know, we always talk about informed consent. Some women don't understand informed consent. Some women don't want to hear it. They have the right to say no even if they haven't been given information. Let's talk about a second example, and that's breech. What's the deal with breech birth anyway? I don't know if you have South Park here in Portugal, but the reason I put that up there is because Cartman has red hair. Red hair is less common than breech delivery, and yet we don't consider someone abnormal because they have red hair. I mean, there may be abnormal people with red hair, but it's not because they have red hair, all right? And the same thing with breech. Breech is far more common. About 1.5% of the world population has red hair. About 3 to 4% of the term pregnancies are breech. Yet we consider breech to be abnormal and red hair not to be abnormal. Okay? ACOG put out in a committee opinion that they reaffirmed in 2010 Those of us at the conference yesterday saw some of these things. We talked a lot about breech, and we did some training in breech delivery yesterday. But even the American College of OBGYN says breech is a reasonable thing. If you have an experienced practitioner, the mother wants it, you have strict guidelines, and true informed consent. Right? So it is a reasonable option. Okay? So why are we told that breech is danger? Well, one is the information that was codified in 2000 by the term breech trial, which I'm not going to get into today because we talked about it extensively yesterday. All right? But this other thing is actually very important. This is Upton Sinclair. He's an author from the United States. He said this around the turn of the century. It's difficult to get a man to understand something when his salary depends upon him not understanding it. All right? And I think it's very valuable. A lot of reasons why breech is danger is because it's inconvenient for doctors who don't know how to do it to refer those patients away. It's inconvenient to have to follow a hospital policy that says if you're going to do a breech delivery, you doctor or you midwife need to be in the hospital the entire time that woman's laboring. Right? We don't get paid enough to sit there for 15 hours when we could be in and out in 45 minutes by doing a C-section. So we sort of use cognitive dissonance to skew our ethics to say that breech is dangerous because we don't want to know the alternative. The skewing of consent, all right? There are several reasons why consent is skewed. We've talked about cognitive dissonance, and this all fits into it. But economics helps skew consent, all right? If you have a hospital that bans VBAC, and in my country, a hospital is paid 2.5 times more money by an insurance company to do a cesarean section than it is for vaginal birth, all right? So if my fiduciary duty is to the hospital, why would I want to lower the C-section rate? Why would I do that? All right? I mean, we all know why we do that, but they have a reason not to do that. Doctors don't necessarily get paid more to do a C-section, but it's much more expedient. It's much easier to just do it than it is to deal with VBAC policies, which also often make you be there the entire time. So the hospitals make policies that sort of make it very, very difficult for people to have the options that they deserve, right? So expediency is another thing that causes the skewing of consent. You know, I don't do that, I'm not going to, but I don't want to tell her that, I don't want her to go anywhere, I only got 4 minutes to go in this room and talk to this woman, so I'm going to give her the information that'll get her to just say yes to what I want to do. Anybody not ever seen that happen? Everybody's seen that happen. Okay, litigation mitigation, this is just a term I have of, in my country and probably your country too, people are afraid to do certain things because they're afraid they'll get sued. All right? They have malpractice insurance, which they pay a fortune for in my country, and the malpractice carriers will often dictate to them what they can and cannot do. So there you have an insurance company dictating standards of practice. Therefore, doctors will skew their consent to stay within the boundaries of what their malpractice carrier or if they've had a bad experience and they've been sued, or if they've had a bad experience or they've been sued once before, they will often skew their consent because going through the legal process in any country is horrible, especially when most of the time you didn't do anything wrong, but it really doesn't matter because it really does, it can destroy you professionally and emotionally. And then ego, all right? A lot of doctors will skew consent because of ego, all right? They don't want to admit that they don't know how to do something. Or they don't want to admit that somebody over there does something better than they do. I'll give you an example of something that was personal to me. 15 years ago, I decided I was going to take a liposuction course, all right? Because it was a way to increase revenue in my practice at the time. So I spent over $10,000 to take a liposuction course. And I came out and I did 3 cases. And I realized, 3 cases in maybe 6 months. And I realized that, why am I doing this? There are guys that do 3 cases a day that are 10 times better than me at doing it. So I stopped doing it because I realized that I wasn't going to ever be the best at this. And I don't want to be doing something to a client when I'm not the best at it. I really wanted to be the expert at it, and I was never going to be better than the plastic surgeons who do this all the time. So even though it was a revenue generating stream for me, not a great one, but it was, I decided that I'm going to put my ego behind me, and I'm not saying this to pat myself on the back, I'm saying this because ultimately my fiduciary duty was to the women that I'm caring for, and was it right for me to say that I'm better at doing your liposuction than Dr. Stevens over in Beverly Hills? No, Dr. Stevens is better at it, so go to Dr. Stevens. And that's what happened. And much of the skewing of consent really boils down to fear. All right? We really end up with doctors who are nervous about things, they're fearful about things, and so what they do is they project their fear onto the women that they care for. In my country and in most European countries, many, many pregnant women are scared to death of being pregnant. They're scared to death of going into labor, of what it's going to do to their bodies. And they're scared to death because the people around them, the professionals around them, are scared to death. If you go to a country, like a third world country like Guatemala or El Salvador in my hemisphere, and you talk to those women, there's lots of them in Southern California, and I get to meet them and sometimes talk to them, and I do speak enough Spanish where I can get away with that. They're not scared of birth because they haven't been culturally told that birth is something that's dangerous, where in our country we have. And doctors will do that. They'll project their anxiety or their fear onto the women. And again, this is so unethically or so ethically inappropriate, and yet it's done every day. And it's not done because doctors are evil. And I'm not picking on, I mean, I know there's a bunch of doctors in the room and there's other people. I'm not picking on us as a group, but this is the topic that I'm talking about today. Because I think most doctors are really good people who want the best for their clients, but the forces on doctors are sometimes unbearable between financial pressures, medical legal pressures, time pressures. In order just to get your job done and go home, you need to do things that you probably wouldn't do if you had all the time in the world and got paid whatever you needed to get paid. Which is part of the reason I feel great doing what I'm doing, because I follow the midwifery model of care, and I give people an hour, 45 minutes to an hour for a prenatal visit, because I can charge what I want, and I can charge what I need to make a living, and therefore a lot of these pressures are taken off of me. Knowledge, we're going to wrap up here soon because I know we're running out of time. Knowledge and good communication are the keys to overcoming fear. Our patients have the absolute right of informed consent and informed refusal. Let's stop projecting our fears and biases on them. Let's please stop doing that. This was a woman who had a VBAC. She had to come down from Portland, Oregon to Los Angeles for the last month of her pregnancy because she couldn't find anyone in Portland who would give her a VBAC. Oh, and one more example, I'll do this briefly because a lot of you know of this case. This is Konovalova versus Russia. It may seem like a very trivial case. It did when I first read it, the first part of it, because this is a woman who had a term pregnancy. She was in prodromal labor. She showed up at the hospital. They sedated her overnight. They gave her IV hydration and some drugs. Either they were too busy, they didn't want to deal with her. They told her that they have medical students involved in their care. She did not want the medical students involved in her care. She did not sign the consent form for it. They actually let her sleep overnight, or they made her sleep overnight. They induced her the next day. The delivery went uneventful, but the medical students were present and they participated in her birth. So for whatever reason, this patient decided to sue in the St. Petersburg court for pain and suffering because her wishes were not respected. The local court ruled that the medical treatment was adequate, which it technically was, and that written consent for presence of medical students is not required despite the legal precedent in St. Petersburg of them needing it, all right? So for whatever reason, the court decided that they were going to just overrule the legal precedent and dismiss her case. Well, this woman was persistent, and she obviously had a persistent legal team because she filed suit in the European Court of Human Rights under Article 5, which was an intervention in the health field may only be carried out after the person concerned has given free and informed consent to it. The person may freely withdraw consent at any time. She never gave written or verbal consent to have the medical students present, and the European Court decided that the claim for any mismanagement or malpractice was denied, but that she was awarded for the medical students being there in the concept of a private life, which encompasses the physical integrity of a person, even if it is deemed of minor importance. And and you and I would think, well, I would think, and I don't know, I can't speak for you, but I would think, okay, it's a teaching hospital, you're there, you're probably getting free care, what's the big deal about having medical students in the room, all right? But she didn't want them, and she made it explicitly clear that she didn't want them, and they did it anyway. It's not allowed. No means no. The ideal would be informed consent to medical treatment is fundamental in both ethics and law. Patients have the right to receive information and ask questions about recommended treatments so they can make well-considered decisions about care. This is the ideal world, of course. And successful communication in the patient-physician relationship fosters trust and supports shared decision-making. The reason that we don't see these conflicts as much in the midwifery world is because the midwifery model of care fosters trust much more so than the obstetric model of care. The obstetric model of care is often dealt with in the shift model, where you work a shift, or you're in a group, and if you have a doctor that you like, but you go into labor, you may only have a 1 in 7 chance of having that person taking care of you. Or in the midwifery model, there may even be a group, but you've met all the midwives. And if there's one midwife that you don't like very much, the midwives will accommodate you to make sure that that person isn't the one taking care of you. And so you end up with a better relationship. This would be an ideal situation. You'll find far less conflict when you have relationships with your clients. But the system isn't set up that way. Sadly, the real thing is about whose choice is it? And this is something I said on my podcast a while back, several years ago, but I'll read it out loud. As doctors and hospitals continue to limit choices and skew consenting for reasons of expediency, economics, and litigation mitigation, women are going to seek out other reasonable options. The ridiculing of home birth, the banning of VBAC, twin, and breech deliveries, and the failure to train future practitioners in these skills is cowardly and unethical. And I couldn't end a conversation about informed consent and ethics without just one slide talking about a topic that is becoming very, very well known in the world. And I'm not an expert on it, but I just wanted to bring it up, that obstetric violence is now a term that is becoming commonplace. And interestingly enough, it appears nowhere in United States law yet, but other countries like Venezuela and Argentina are beginning to define it as a crime against people giving birth. And there's a documentary film coming out probably in the fall that I'm financially supporting, called Mother May I, and it talks about several cases it presents, including a very big one you may have heard of where a woman won $16 million in Alabama for a case where she was crowning and the nurse held the baby in her vagina for over 6 minutes while they waited for the doctor to come, and they wouldn't let her push, and she ended up with nerve damage and pelvic floor damage, and now can't really function. And the idea that some of you have your hands over your mouths and stuff like that, the idea that that would ever happen anywhere, including, I'm not specifically singling out American hospitals, but that would happen anywhere, that a woman says, I have to push, and the nurse says no, okay? And not only does she say no, but she physically touches the woman and restrains her, all right? That's something that just can't happen anymore. And obstetric violence is going to be a term that we're going to hear a lot about. So there are people in here probably know much more about it. I know there's some lawyers in here and stuff, and I would like to hear more about that. I don't know if that's something that's going to come up today, but I hope it does. So thank you for your attention. If there's time for questions, I'm willing to take questions. And the Dalai Lama said it really well. He says, when you talk, you are only repeating what you know. But if you listen, you may learn something new. So thank you.
Está a funcionar. Muito obrigado. Vamos ter agora 5 minutos para questões. Pedia que fossem claros ou claras e concisos e concisas nas vossas questões, também que falassem bastante devagar, mas que fossem diretos à questão, para que os tradutores também possam traduzir. I'll now ask you to put your translation device.
Oh.
Muito obrigada.
Yeah.
Não sei se está a chegar a tradução. Está a receber com a tradução?
I'm not hearing anything. My battery dead? Say something.
O meu nome é Isabel.
The little red light went off. Is that? Yes.
Não sei se agora já consegue.
Yes.
Sim. Ok.
Okay.
Muito obrigada pela apresentação. A minha questão está relacionada com a questão que usualmente me colocam quando se fala deste tema, que é a questão, o facto do feto não poder dar o seu consentimento. Eu também tenho a minha opinião relativamente a isto, mas gostava, se fosse possível, só que falasse um pouquinho sobre isto, que eu tenho certeza que também já teve esta questão. Portanto, a mulher que diz que não, que recusa uma determinada intervenção, que a equipa de profissionais acha que é fundamental para a saúde daquele feto. E aquele feto não dá para saber se recusa ou não.
So this is an extremely difficult question, obviously. Oop, now I've got this guy talking. This is a very difficult question because for me, I believe the fetus has rights, but I don't know that legally you can force my understanding. And again, if there are lawyers here, they would probably speak better. But the absolute right belongs to the woman. So you cannot invade her body to do something to the fetus. All right. I mean, personally, I think that's abhorrent. But I don't know how you can violate one person's rights, even though. So if that's what you're asking, I don't have it. Again, I'm just an OBGYN, and I don't have the answers to that question. That's a very, very difficult question. I would love to hear what other people have to say about that. But I think the way it stands right now, and at least in my country, is that they can get court orders to do like C-sections on women against their will, but ultimately, with the changing tide and what I've just told you and what Hermine Hayes-Klein has taught me, is that's going to be much more difficult in the future. Ultimately, the woman is going to be able to have control over her own body. Okay.
Outras perguntas?
Hi, I'm Silvia.
Oh.
Em português, para depois fazer a tradução.
Yeah.
Deve estar mais. Tá, sim. A minha questão é, independentemente do consentimento que um pai tem que ter informado pelo seu médico, se não tem que começar a existir uma maior responsabilidade dos pais para compreender o que é permitido e o que é que faz sentido para eles, não estando exclusivamente dependentes de uma entidade externa para lhe passar informações e permitir esta decisão. Eu acho que também tem que haver alguma responsabilidade dos pais para compreender a informação que lhe está a ser dada e que de forma é que faz sentido ou não para as certezas que eles têm. Pais e mães. Sim.
I'm not sure I'm getting the question exactly, all right? But what I think you're saying, are you asking me what are the father's rights? Well, ultimately, in my country, if the woman is competent, all right, legally competent, which means that she's not under a psychiatric problem or you know, that sort of thing, that as far as consent goes, you don't need the father's consent to do anything to the woman. The woman is solely in control of her own body. In an ideal situation with communication, at least in the midwifery world, we include fathers in everything that we do if they want to be included, all right? But legally speaking, all right, if the woman is competent to make a decision, then she doesn't need permission from anybody else or release from anybody else. Does that answer your question? All right, you want to ask it again.
Just to talk more to the microphone.
Oh, sorry.
Because of the translation.
Sorry.
Tem mais a ver com a responsabilidade de ambos os pais no processo decisivo. Independentemente de um médico lhe dar a informação que a mãe não deve fazer uma cesariana ou deve ter um parto natural após uma cesariana, a mãe também deve estar informada, também deve ser responsável pela sua decisão, mesmo não seja através da informação que o médico lhe dá. Se fará sentido também isso?
No, it doesn't. Still doesn't make sense to me.
Basically, what she's asking is, isn't the parent's responsibility as well to gather information beyond that of what that doctor is saying?
Oh, okay. Oh, okay. All right. Sorry. Yeah. Yeah, I mean, listen, everybody has the right to gather as much information as possible. As a matter of fact, you have the responsibility to do that. What's interesting is when you go into a doctor's office with information, you can actually judge how good your doctor is by how well he accepts or she accepts the fact that you've come in with information. Doctors who are open-minded are going to say, that's very interesting, this article is a really good article, or this one's garbage, or whatever. They might say these sort of things, but they'll be welcoming to the fact that you came in with that information. Doctors who are ego-driven are going to say, who's the doctor here, me or Dr. Google? You know, that's what they're going to say. But, oh yeah, no, you can't have too much information. You can't make informed decisions without information. So it behooves you and your partner or your mother-in-law, or anybody else to get as much information as possible. But ultimately, the final arbiter of the decision, it needs to be the couple, but ultimately the woman, but usually they come together with a decision, and that's what makes them a great couple. All right. Yeah, I got your question. Yes, you shouldn't rely on information you just get from your physician or your midwife. All right. Now, again, if you have a trusting relationship with them, then that makes them feel comfortable. They're fine. Other people will, you have a sixth sense. We all have a sixth sense that we're getting bullshit sometimes. If that's translatable, I don't know if that's translatable. Okay, but when you're getting BS'd, you can often sense it, and if you are, there's never a reason not to change. I mean, I don't know how it works in Portugal, but I know in our country, if you get to be 36, 37 weeks, we have what's called a bait and switch. It means the doctor's been really supportive all along of your attempt to do a VBAC or something, and then they change their mind, and they start to tell you reasons why you shouldn't have it. And then at that point, sometimes it's very difficult because of the financial way people are reimbursed for a patient to leave that doctor and find another doctor, all right? We in the midwifery world, we tend to be a little bit more open to taking people later in the pregnancy, but some midwives don't want to either because their whole model is based on developing 5, 6, 7-month relationship with somebody, and meeting somebody new makes everybody a little more uncomfortable, especially if labor comes right away. But don't settle for a physician or a midwife or anybody who doesn't seem to be responsive to what you want to know, and or doesn't seem open to the fact that you may know stuff that they don't. All right? I feel very, when you're feeling really comfortable in your role, people ask me questions all the time. They'll say, "What do you think about this nursing bra?" Okay, and I'll go, "I don't know anything about nursing bras, but here, ask Beth. She's the midwife. She knows all about them." And I don't have any problem saying what I don't know, because I'm confident in what I do know. Okay.
Obrigado. Nós vamos ter de ficar por aqui pelas questões, mas Stuart Fischbein vai estar connosco o resto do dia e vamos ter tempo para, ao longo do dia, lhe colocar mais questões. Muito obrigado. Thank you. We'll stay.
All day.
Yeah.